Hey everyone, welcome to this second OSCE for this week, or second session this week. We're only doing two this week, so kind of condensed the three into two because of the bank holiday on Friday. So yeah, we've gone over a little bit more than we normally would on the Monday session. So hey John, so this is kind of like the summing up session. I know we gave you some indication of what might be going on with this particular client in the first place. So just going to explore those in a little bit more detail and why we got to those conclusions. Okay, so I recognize all the names, so I'm going to skip all the introductions and stuff. So we had a scenario that I mean, to be honest with you, some elements of this are out of my remit as well. We're very lucky where I work in Birmingham. We've got a very good female health physio. Well, we've got a few of them, and they're in the same suburb of Birmingham as me, literally about, I don't know, less than a mile away. Their clinic is over there, and they specialise in pelvic girdle pain, pelvic health, and especially pre and postnatal clients. So anything like that, I pass on to them, and any MSK stuff they pass on to me. So we work together as a partnership within the local community, referring patients between each other. And I think that's important, really. We've talked about it a few times about knowing your remit and then passing on. And pregnancy is something that I covered on my degree program, but not in any great depth. So it's an area where I would prefer to pass it on to someone who specialises in it. Okay, so obviously it's good to know about some of these things, but yeah, sometimes it just falls outside of our remit. So a couple of people to look for. There's a lady who works with us called down the road from us called Fiona Mitchell, and Fiona she runs courses with a chap called Gerard Green, and he looks after the male pelvic health kind of physio arena, and he teaches the courses on that. And Fiona works with him teaching the female pelvic health courses. So if you're looking for someone in your local area, then it will be definitely worth searching those two names. So Fiona Mitchell and Gerard Green. And if you contact them, they may have contacts in your area for people who specialize in pregnancy physio or postpartum physio or whatever it is. Okay, so well worth researching that, just in case one of these clients does come through your door, if that's not your area. So this was a summary of the case. So our lady, she was 35 weeks pregnant. So obviously very far down the line in terms of her pregnancy, and it's her first baby. She was getting heartburn and gastric reflux, kind of usual symptoms for that late stage. The midwife had picked up that there was something wrong with her urine, and there was a clue within the case history to say that they think there might have been protein in the urine. So we'll have a bit of a discussion about that in a sec. She was originally from France and had moved over to the UK only quite recently. So there were a few kind of social issues going on, and or potential social issues. And her husband left her a month ago. Nice of him, just with a few weeks to go of the pregnancy. So again, another added layer of social issues and psychological issues, especially around being in a strange country, and obviously the person that you've come across with or moved over for has up and left. So we've got a few issues going on there. She came in complaining of a couple of things. So her main complaints were her difficulty walking and her shoulder and neck symptoms. But on further investigation and doing an examination, we found out some other things as well. And this is the whole point of this, is not just to ask questions about the things that they've come in with, but some other things as well, and exploring all of the body systems, not just the musculoskeletal side. And that's where the sieve comes in. Okay, so yeah, so she'd had some difficulty walking and discomfort at the symphysis pubis, which is the point at the front of the pubic bone. You've got a little fibrocartilaginous structure in there that provides an element of movement at the front of the pelvis. Okay, so and we talked about this as well, that there's a hormone released during pregnancy and afterwards as well. It's still in the system, which causes the ligaments to become slightly more lax than usual. So that's called relaxin. And so it's quite common for, especially during this late stage in pregnancy, for the relaxin hormonal changes and the additional weight of the baby, now it's nearly full term, changing the orientation of the pelvis. Yeah, so normally your pelvic ring is quite a solid structure, but in this stage of pregnancy there is some a potential for laxity. So there can be an issue where the pubic symphysis, or the pubic bones at the front can move slightly and irritate that ligamentous structure and the cartilaginous structure as well at the front. Can often get like groin symptoms because a lot of the short adductor muscles attach onto the pubic rami, and those can become involved as well. So yeah, she was complaining of that, and she was having difficulty walking with that. And then this was probably one of the biggest things. So her face appears a little swollen. She had visual disturbances, swelling over the anterior aspect of both ankles and wrists. And she'd had her blood pressure checked and her blood pressure was raised. We're going to talk a little bit more about that as well. She'd also had, which is kind of layered on, and it is always the case with these kind of OSCEs, is layered into it are some musculoskeletal, like normal issues as well. So she's had 10 months of intermittent pain radiating from the spine of the right scapula over the right levator scapula and supraspinatus muscle to the right shoulder. Okay, so this kind of region here. And she'd also had pins and needles over the right supraspinatus area and into the right hand and wrist, with coldness and numbness in the arm when carrying weights. Again, we'll talk about why that might be. They related it mainly to occupational. It was occupationally induced, and she was a secretary, and they mentioned as well about her holding a phone to her neck all the time in that position. So if she is right-handed, then you can imagine holding a phone in that position for that long will close up the space in the neck and could irritate the neck. So that could be one of the reasons why she's getting these symptoms. She's got a textbook preeclampsia. Yeah, exactly. So 3 months history of stiffness in the feet, inability to stand for prolonged periods of time, and direct pressure onto the soles of the feet is sore. And again, this is a classic one. So well done there, Peter. Yeah, textbook preeclampsia. With postural muscle overuse. Yeah, really good. So an element of postural fatigue, and with the additional weight at the front of her body as well, it's going to further pull her into that kind of kyphotic position and being at a desk all day. So there are some things that we may be able to recommend if she didn't have all the other problems with her workstation that might help her out with some exercises and moving around and posture variability. Yeah, so changing the position that she's in at work quite frequently. She'd had 2 weeks of headaches as well. So these headaches had just started, and a family history. Her father had had an MI, which is a myocardial infarction, a posh word for a heart attack. And her sister had something called Wolff-Parkinson-White syndrome. So we're going to have a look at that in a bit more detail as well. Okay, so that's a summary of the whole case. And then from that, picking out the key bits. So preeclampsia, and some of you have mentioned this in the messages to me as well on the Facebook group and privately, so that's really good. And the reason for that is because of the urine issues. Okay, in the case history, it wasn't specific, and because she couldn't remember. Yeah, we would assume that she's got proteinuria, so protein within the urine. Okay, and we'll talk about why that happens with preeclampsia in a sec. High blood pressure, which again, we didn't know for sure. And this often happens as well when patients come in and they say, oh yeah, I think my blood pressure is high. And you say, well, what was the reading? And they don't know, they can't remember. And it's not their fault, they can't remember these things. But if that's the case and you know how to do it, really, you should be taking blood pressure just to check. So you're not just taking their word for it. Yep. So yes, that's right, Peter. Yeah. So you with this case history, you would get her to leave your clinic and go straight to the GP or midwife. Yeah. Or make the call in the clinic to have an emergency appointment. Yeah. So it could be that serious that it could be life-threatening to both her and the baby. Okay, so yeah, I would with this one. I've put visual disturbances in there twice. Maybe I had some visual disturbances. So we've got swollen face, wrist, ankles, visual disturbances, headaches, and it's her first pregnancy as well. So all of those things are classic preeclampsia, as Peter mentioned there. Would hope regular antenatal checkups repeat. Yep, exactly. Yeah. So I think with the case history with this one, she was in between midwifery appointments and wanted to come and see it. And this is typical as well of patients. They may have other stuff going on, but their neck hurts. Yeah. So they come to see you with their neck, but when you further question things, actually, there's something else more pressing that's a problem than their neck pain. And they may not notice the other things going on because their neck is killing them. So and it's up to us to question these things and delve into them a little bit deeper. But that's really good, John. The other thing with which we picked up last time as well, thoracic outlet syndrome. And the reason why it might be worse with the weight in the hand is when you're holding something heavy, it will depress the shoulder girdle, and that compresses the clavicle against the top of the rib cage. And if it's a vascular claudication, so basically stopping the blood flow, it can occlude the subclavian artery. So if you're squashing it, but by carrying something heavy, then your hand will go numb and it will go cold. Okay, so that's something to just to bear in mind. So we had a bit of a chat about some of the tests. The best one is Adson's. That's one of I think it's got the best sensitivity. I can't remember the exact figures off the top of my head. But then you have also got Ruse test, where you have your hands up like this, and then you pump the hands. Okay, you do it on both sides, and you wait to see if the fingers go tingly and numb. That's not a very specific test, that one, because most people's hands will go tingly and numb if you do that for a minute. Just having your hand up in the air might do that. So it's not a great test. And then you've got Wright's test, which if I do remember correctly, this is one that Namir said, yeah, great. It's kind of like a military posture, 79%. Okay. So you think it was in the 70s. I thought, yeah, cool. So if you got military posture and then down, very good. Well done, guys. Then that again will occlude that subclavian artery. Okay. So if you, yeah, it's like a military posture position. So it's really classic to get thoracic outlet with, especially in the military, by having a big Bergen on your back, and then it's weighing down your shoulders and it just crushes your clavicle against the top of your rib cage. Okay, cool. So that was those two. Then we have a possible nerve root compression because of this position of the head. Okay, so and the area that may be affected because of the symptoms they're getting is C5, C6. So C6 affects this part of the hand, specifically dermatomes, and that there'll be this kind of area of the shoulder as well may be affected. That's usually kind of C4, C5. So if they're getting kind of like weird symptoms around this area, maybe going down into the hand, could be nerve root. Is thoracic? Yes, it is. In my experience, thoracic outlet is very common. And can we treat it if we suspect it? We can, in a way, yeah. So what you can do is ease the aggravating factors. Okay, so if carrying something heavy in the hand is aggravating it, then we obviously advise not to do that or reduce the load. And then there could be a number of reasons for it. So it could be neurogenic. So there may be some nerve tension. So you can do nerve tension tests and nerve tension exercises for the median nerve, especially. We talked about that on a couple of sessions ago. But you can do something called, which I've put down here on the carpal tunnel section, an upper limb tension test, a ULTT. So you can do an upper, that's the, we did a penguin test a few weeks ago. And you can test the radial nerve and you can test the ulnar nerve for tension within those nerves. And if you do detect it, then you can do some very gentle exercises for nerve mobilizations. Okay, so that's something you can do with that. Where the nerves come through, so the brachial plexus, it comes through between your middle and anterior scalene. So if you're doing that all the time, holding a telephone receiver to your ear, well, one thing you recommend is wearing a headset, so you don't have to do that, or wearing earbuds or whatever they've got. But you can do some manual therapy to the scalene muscles to reduce the tension here. The other area it goes is underneath your pec minor muscle. So you can do some manual therapy to the pec minor muscle. If she's struggling with the kyphotic posture, we can do some retraction exercises. We can do some stretches or METs for the front part of the chest. The other area it goes, and another kind of trackment point is underneath a muscle in your forearm called pronator teres. And you can do some manual therapy to pronator teres as well and work in between the ulnar and radius bones. And you work all the way down there with manual therapy again. So you can treat neck, pec minor, and the muscles in the forearm, and you can do nerve mobilizations. And the exercises as well, and the modifications. So there's lots of things that we can do to try and help thoracic outlet syndrome. However, it might not be postural, it could be structural, and you can actually have a cervical rib. So on the C7 transverse process, some people have a rib, and they're not supposed to be there. Supposed to be, the first rib is supposed to be at T1. So if you've tried everything, you've done all the nerve mobs, you've done some work on the neck, and it's just not getting any better. And I've had a patient with that, then they go for an X-ray to see if they've got a cervical rib. Okay, and if they've got a cervical rib, there's nothing you can do about that, but you can have an operation to have it removed. Okay, so it depends on the causes of it. There may be some things that are modifiable, but there might be some that are non-modifiable. How soon would it pass with doing those? A few days. Again, it depends really. It depends on how much they're aggravating it and how long they've had it for. I think if they've not had it for long, it's quite easy to figure out what the things are that are aggravating it and then modifying those things. But she's had it for 10 months. So it's probably going to take a little bit longer to ease off. And you also need to think as well that not all symptoms come from the structure. So she may be feeling these symptoms in her neck more, an elevated level of discomfort because of all the other stuff that's going on in her life as well. So if she's worried about her husband, she's worried about work, she's going to be off in a bit with a little baby, then there's all those things that are going to be feeding into her sensitivity with her pain. Okay, so the painful symptoms may not just be because of the structure, it might be overlaid, and that's that biopsychosocial approach. Okay, so yes, we want to have a look at the biomechanical stuff, but we also need to consider the psychological and social elements of what she's dealing with as well. Okay, I think I have a knitting 86-year-old with it. Okay, I've had a client I suspect has it and gave a few sort of decompression stretches and got instant relief. Yeah, cool. Yeah, we've had I remember a colleague of mine, there was a lady, this was for carpal tunnel rather than thoracic outlet, but often the two are linked. And she was just about to go for surgery for carpal tunnel, and she was a concert pianist. She was a very, very good pianist. And so yeah, she would have to been off work for several months to recover from the operation. And my friend did a nerve tension test on her, got her to do some very simple exercises, and it went in a week. Yeah, so sometimes it can go really quickly, and sometimes it takes a lot longer. So it just depends. Sent those types of stretches yesterday. So yeah, brilliant. Well done, Natalie. That's really good. Cool. So yeah, with the nerve root compression, you can do a test called Sperling's test. And you're looking for reproduction of symptoms. And what you do is you extend the neck and you side bend and rotate to the side that's sore. And then if that is bringing on the symptoms, then that will be a positive test. If it doesn't bring on the symptoms, then you push down on the top of the head to try to squash the vertebra. Okay, so you're basically trying to recreate the compression to see if it produces the symptoms. And then if it does, and then when you decompress, so you kind of lift the head up, lift the skull up, then the symptoms will ease. So it's likely then with Sperling's that they have a nerve root component to their issue. Okay, and it's something that you can use as a differentiator between a neck problem or a thoracic outlet problem. Right, that's the kind of thing that we would do. And because there's nerve symptoms, anybody with any kind of neuro symptoms need to do a neurological exam. Again, if you know how to do those, so that would be reflexes, sensitivity tests, power tests, yeah, sharp, soft touch. Okay, and vibration sense as well. So we would test all of those just to make sure that the sensory nerves are intact. Okay, and the motor nerves as well with the power. Cool. Then we've got pubic symphysis dysfunction. So that because of the pubic bone symptoms and pain on walking, for me, that's out of my remit. That's not really something I would deal with. I would send that one off to a pelvic health specialist physio. Okay, that it's not something I would feel comfortable treating, to be honest. You may do if you've had specialist training. If you're in the fitness industry, so if you've come from that background, there's a really good trainer called Jenny Burrell, and she does a lot of pre and postnatal courses for fitness professionals, and she works with Fiona Mitchell, the lady that I mentioned earlier. So Jenny Burrell in the fitness industry, and Fiona Mitchell and Gerard Green in the kind of physio world. Okay, again, not out of my remit, that one I would pass that one on. Carpal tunnel kind of linked into the thoracic outlet issues, but because of the problems with the hand. Now, the thing that would move this down my list is that it's not in specific fingers. So usually carpal tunnel syndrome will affect the median nerve. Okay, well, it does affect the median nerve. And the reason why it does is because the median nerve goes underneath a ligament that crosses over in that part of your wrist. Okay, so the median nerve will go underneath that ligament. So if you have increased swelling, which you usually do with pregnancies, this is quite common in pregnant ladies, then it reduces the space underneath the carpal tunnel. Okay, which will then compress the nerve, and then you get symptoms in your thumb, this finger, this one, and usually about half of that one, and it's specific to the fingers. Yeah, it doesn't usually get the pinky. So if you're getting whole hand symptoms, it's usually blood supply. Yeah, there's a blood supply problem usually. It may be both, because the ulnar nerve supplies the little finger and the other half of this one. Yeah, so you've got ulnar nerve here with a U, and then median nerve there with an M. Okay, so median nerve, ulnar nerve. Yeah, and but if it's whole hand and it's not in that specific distribution, then it's usually a blood supply issue. So you're looking at possibly a thoracic outlet type syndrome. So that's something else to look out for. And that's what was mentioned in the case history. Yeah, so it was a whole hand problem rather than specific fingers. So if someone comes in and they say, oh yeah, I've got tingling and numbness in my hand, you say, is it in certain fingers? Okay, and if they say no, it's the whole hand, then immediately you should think, right, blood supply, and then do a thoracic outlet test. Okay, if they do say it's specific fingers, you need to do a neuro exam. So you can work out what's going on from the kind of things they say. And then the last one was a plantar fasciopathy. So but basically plantar fascia pain. So because there's pain in the sole of the feet. Again, it's very common with pregnant ladies, and you can do something called a Windlass Test, where you lift up the big toe and see if it reproduces their symptoms. On the physio tutors videos, it says that one is 100% specific. Okay, I don't know whether there's been any update of the research since that video was produced, but there's 100% specificity with that Windlass test. So if it's positive, then they probably have it. You can, if you're not sure or you think it might be something else, they're not responding very well to the treatment, which for me would be a combination of some manual therapy, wearing something called a Strasbourg sock at night, which pulls the big toe up, helps to elongate the plantar fascia during the night, and strengthening exercises for the sole of the foot. So what you do, you get a towel, rolled up towel, you put the big toe on the towel, and then you do calf raises with your toes in extension. Okay, and that elongates the fascia as you're coming up onto your toes. Okay, so that's a real good one that I've found with my patients. And a golf ball in the freezer, and then use that to rub the sole of the feet just to desensitize the area. Okay, so I kind of like hit plantar fasciopathy with a shotgun and do all of those things and create a little bit of a routine for them, a daily routine. Cool. So that was a kind of overview of all of the things that it could have been. I mean, obviously there could have been others, but those were the things it was most likely to be. So just going to have a look at preeclampsia. So all of this information is available on the NHS website. Sorry, the text is so small. I couldn't get any bigger without messing up the whole thing. So basically there's a problem with the placenta with preeclampsia. You've got narrowed arteries that supply the fetus. Okay. And because of those narrowed arteries and there's a lack of blood supply to the fetus, you then get pro-inflammatory proteins that are released. And they cause a cascade of changes within the blood vessels of the body. So they get released into the bloodstream, and then that causes vasoconstriction. So the blood vessels in the whole body start to narrow. Okay, if you imagine like a hose, and you've got your tap on, and you're just watering the plants or whatever. If you squeeze that hose and make the hose narrower, then it increases the pressure. Yeah, so the blood pressure is going to increase if there's vasoconstriction. Okay, the release of those inflammatory proteins also causes the kidneys to retain salt, which also increases blood pressure. Okay, and we talked about this last time, that the high blood pressure for pregnancy is 140/90. Okay, I'll show you a little video on some blood pressure tips in a sec. You also get local vasospasm of other areas of the body as well. And so that means you're going to get reduced blood flow because the arteries are narrowing in the kidneys, which further affects your blood pressure, and in the retina. So that is why you get visual disturbances, because the blood supply to the eyes is interrupted. Okay, so that's why with preeclampsia you get blood visual disturbances, and you also get protein in the urine because it affects the kidneys as well. Okay, so that those and you get the swelling because you can't process the fluid in the body because the kidneys aren't working very well. Okay, so there's a whole cascade of things that happen, and well, I'll show you a little video in a sec. So early signs of preeclampsia include having high blood pressure and protein in your urine, which we think this lady had. It's unlikely that you'll notice the signs, but they should be picked up during your routine antenatal appointments, which is exactly what you said, John. Yeah, they should be. Okay. If they're in between appointments or something's gone on, or they've come to see you about something else, then it's worth checking these things. So I often say about doing postural analysis and the limited validity of doing a postural analysis. Now, this is where an analysis of someone's posture is really useful, not for the posture, but to have a look at their whole body and to see if there's any obvious areas that don't look right. So if you notice that the ankles are swollen and the wrists are swollen, you wouldn't notice that unless you'd done a postural analysis. Okay, so do the kidneys explain the pain below the ribs that often comes with preeclampsia? I think that's also to do with the liver. I'd have to check, John, but have a look on the NHS website. Yeah, I think it might be to do with the liver, but yeah, I could be wrong with that. So have a check. So yeah, in some cases, further symptoms can develop. So you get swelling of the feet, severe headaches, vision problems, and then the pain just below the ribs, as you mentioned there, John. Okay, so let me just show you this. This is a little video from the NHS.
To grow as we would put both the mother and the baby's health at risk. It may lead to your baby being born prematurely, or your baby failing to grow as we would expect in the womb.
How would I know if I'm at risk of preeclampsia?
Early indications of preeclampsia are probably going to be picked up by your community midwife or your GP at an antenatal check. Women with preeclampsia have high blood pressure and protein in their urine.
Okay, let's do your blood pressure there.
They test your urine for protein and they check your blood pressure to make sure it isn't high. Sometimes preeclampsia can come on quite quickly and you might be the first person to notice the symptoms. In particular, swelling, especially in the face, the hands, or in your ankles. You might have a really bad headache that just won't clear with normal painkillers. Your vision may be blurred. You may feel just really generally unwell. And in severe form, sometimes it can cause upper abdominal pain just under your rib cage on your right-hand side. If you're not sure, go and see your midwife as soon as possible, or your GP, and let them check you out. Some women are more at risk of...
Okay, so just thought I'd show that video. So if you just search NHS preeclampsia on YouTube, then that video will come up. Obviously, you can have a look at the rest of it in your own time. But those were the key things that came out in that case history. So it's like classic preeclampsia within that story from that lady. I just want to show you this as well, because this might be of use to you. Just before we get going on that, this is a really, really good YouTube channel. It's called Geeky Medics, Geeky Medics, and it is designed for doctors who are doing OSCEs. Yeah, so these are the kind of OSCE exams that doctors would do. So this is what they expect for someone who's doing a blood pressure check.
Hi, my name's Simon.
My name's Simon. I'm one of the final year medical students.
Can I just check your name and age?
Can I just check your name and age?
My name's Andrew and I'm 25.
my name's Andrew and I'm 25.
Nice to meet you, Andrew. Today I'd like to take your blood pressure. So that will entail me taking this cuff, inflating it around your arm, feeling and listening to your pulse. Does that sound okay?
Yeah, that's fine.
It might be a little bit uncomfortable, but it shouldn't hurt.
That's all right.
Are you okay for me to go ahead?
Yeah.
Lovely. If you just pop your arm on the table, that's lovely. Fine.
Here's one I prepared earlier. So on a blood pressure cuff, you've got this mark here, yeah? And it's got a little arrow on there. And what you do is you line that arrow up with the brachial artery. So you can find this on yourself. So if you're wearing a t-shirt, then it'd be easy. If you're not, roll up your jumper. And if you tense your bicep and then feel where the bicep tendon is, just medial to that is where your brachial artery is. And if you put your two fingers in there, you should be, if you push hard enough, you should be able to feel the brachial pulse. Yeah, so that's where you need to line up with on the blood pressure cuff. Okay, I'll just show you the next bit.
And I'm just going to feel your pulse now.
Okay, so this bit This is how we were taught to do it as well. So you have a feel of the pulse in the wrist, okay? You pump up the blood pressure cuff around the bicep, and you feel at the point when the pulse drops off. And you have a look on the device on the dial to see what level you get to of blood pressure before the pulse goes. And the reason why we do that is so that you know once you've got your stethoscope in, you know how far to go up in terms of the pressure. Okay, bear with me a second. Sorry, someone keep on messaging me. Okay, yeah, so you know how far to go up in terms of the pressure. So when you've got your stethoscope in and you're pumping up, you don't have to go too far. And that this is the beauty of using these over an electronic one. You can make it specific to the individual. But also when I'm doing that, I'll know pretty much straight away if they've got high blood pressure, because if their pulse is still going and the dial is at 150, then I know that their systolic blood pressure is quite high. Yeah, so I'll be expecting a high result. But I'll just show you the rest of it. If you've had it done before, then you'll know what's coming. So I was just saying, what I'll do between now and next week, I'll create a video of how to use that blood pressure cuff. Yeah, thank you. And what to do. Okay, so you just in case you missed it, so they pump up the cuff around the upper arm so that it stops the blood supply. Okay, so you feel for the pulse and then it will stop because no blood is getting through. And then you slowly let the air out of the cuff and you feel for when it starts coming back. All right, so it'll give you an idea of what their upper systolic blood pressure is. All right, and so then when you come to use the stethoscope, you've got a better idea of how much air you need to put in the cuff. Okay, should have handy as well. Do you know what? I think it's a good question by Natalie there. So would this be something a sports massage therapist should have handy as well? I would say, yeah. I mean, for me, anybody who's got a headache, anybody who's got whole hand symptoms, I'll do their blood pressure just to check to make sure it's normal. It's one of those things again where, see, the thing is, if you suspect someone has high blood pressure, if they're pregnant, it's a different risk altogether. If they're not pregnant, then high blood pressure is not one single reading. High blood pressure is consistently high over several readings. So that's really not for us to do. But what we can do is if we notice that it is high, we can say, do you know what, I think you need to go to your GP just to get checked out. Because on my machine, because it takes a bit of practice using the stethoscope one, the machine is a lot easier. I don't think it's as accurate for me. It's close, but it's I prefer to use the stethoscope, to be honest. The old-fashioned system, but it's one of those where you can go, yeah, I think you need to go to your GP to get checked out. Okay, but I think it's a good thing to have in your armory as a sports massage therapist or sports therapist. And years ago, when I was a fitness instructor, we used to do this on every single appointment. Yeah, so any new people coming in, we would take their blood pressure. I think I mentioned a story maybe last week about someone that we picked up who had high blood pressure and didn't know. So he was referred to the GP and then put on medication. Could be true. Yeah, exactly. This is the thing, Natalie. I think if they are on medication, and especially things like beta blockers, things like statins, all those kind of things can affect your blood pressure. And if they've got a pre-existing heart condition, then obviously their blood pressure is going to be different from normal. But again, if it falls out of your remit, I wouldn't bother doing it. Yeah, because you could scare the person and scare yourself, thinking that there might be something wrong with this individual. So it's one of those that if you feel confident and you've been shown how to use it and you've been assessed using it, then give it a go. But if all you've done is watch a YouTube video, then the competency check isn't there. Okay, so you would need to you would need to make sure that you're competent to be able to do a blood pressure check. Okay, and yeah, absolutely, John. Yeah, you'd need to have consent as well, because it's not something that you would normally expect a sports massage therapist to do. Yeah, so it's if it's one of those things where you've done the course and you're happy to do it. There used to be like health coach courses in the community, and they used to do regular blood pressure checks, and it was like a level 2 course or something that you could do. And I'm not sure whether they exist anymore, but it's worth doing something like that so that you can get checking blood pressure to make sure that you're doing it correctly. Okay. Yeah, absolutely. Well, this is the thing with testing blood pressure. There's a number of factors that can lead to higher blood pressure, and it may be nothing to do with their cardiovascular system. So this is the thing with checking it. You can have really high blood pressure one day, and then the next day in the morning it's really low, and it's nothing to do with your blood pressure. It was just you were stressed, or you rushed to an appointment or something like that. So you've got to be careful with the kind of things that you the information you glean from those assessments. Yeah, exactly, John. Yeah, exactly right. Cool. So a couple of things that I would check. And again, if you've got the competency to do it, then that's what should be done. And I think that's the thing with this, is just making you aware that if they have this issue, they need this check. If you can't do the check, you need to refer them on. And if you work in a practice where you can refer to someone quite quickly, then you can say, "Oh, do you mind just checking their blood pressure for me?" Then they can do it really quick, and it's done and dusted. Yeah, but if not, then you'd have to go through a referral route if you were worried at all. Okay. And then the last thing, just to finish off, is Wolff-Parkinson-White, and I think I've had 3 patients who've had this. It's nothing really major to worry about. It's quite common. So if you have Wolff-Parkinson-White syndrome, you may experience episodes where your heart suddenly starts racing. They call it supraventricular tachycardia. So tachycardia is where the heart beats really fast. Bradycardia is where it beats really, really slowly. Okay, so this one is a tachycardia. The reason why is it's a congenital reason. They're born with it. They have an additional connection in the septum of the heart. So you've got something called the Purkinje fibers that come down from the node in the heart that controls the heartbeat. And as the signals come down, they supply the ventricles, and then the ventricles pump. Yeah. In people with Wolff-Parkinson-White, they have additional connections that are separate to the Purkinjes, and it's called the bundle of Kent. Right. So the problem with that is that usually the heartbeat is controlled by this SA node, the sinoatrial node, but because they have these additional bundles, these additional electrical conduction fibers, they don't have control over it, so the heart beats quite rapidly. Okay, they can live with it. It's not a problem. Yeah, they may need to adapt some of the things that they do, but it's not going to be life-threatening. It's just something that you need to keep an eye on. Okay, and obviously, if you experience any other kind of heart symptoms like pain going down the arm or up into the jaw, then they might be having a heart attack. If with Wolff-Parkinson-White, you can quite happily live with that, and you'll be fine. So usually they'll get a pounding or fluttering heartbeat, feeling lightheaded or dizzy, short of breath, chest pain, sweating, feeling anxious, those kind of things. So if you think, oh my God, is this Wolff-Parkinson-White, or are they having a heart attack? You need to call 999. Okay, but usually it's fine. And people can live with it, no problem at all. So if you've not heard of it, then that's what it is. And again, you can have a look on the NHS website, and there's some really good information on there with that as well. Okay, so that's it for today. That's it for this week. So we're going to do a new one next Monday. Week 8 next week. Crazy. I can't believe how quickly this time has actually gone. But yeah, really good questions today. Some good flowing backwards and forwards. I'm doing a session next Monday at 8 o'clock as well with Dan Lawrence. Dan's going to be talking about nocebos and placebos, and I'm going to be talking about communication with patients and using some of the teacher training that I've had and how I use that teacher training with communication with patients. I'm planning instead of planning a lesson, I'm planning a treatment session. Okay, so that's what we're going to be covering next week at 8 o'clock. So I know, so next Monday, 6 o'clock for the OSCE, and then 8 o'clock with me and Dan for clinical chat. I will hopefully see you then. Have a good bank holiday weekend. Cheers, guys. Take care.